Good afternoon,
Welcome to the NMR Medical Webinar with Dr. Charles Atwood of the VA Pittsburgh Healthcare System and UPMC Sleep Medicine Fellowship. Audiocast quality is subject to your equipment, available bandwidth, and internet traffic. If you experience unsatisfactory audio quality, please use the telephone dial-in option provided in your confirmation and reminder emails. If you have called in, operator assistance is available by pressing £0. You may send questions at any time using the chat window located to the left of the presentation screen. A question and answer session will follow the presentation. I'll now turn the call over to Dr. Atwood. Please begin.
Thanks very much. Welcome everybody to the webinar on understanding how the PAT, peripheral arterial tonometry signal, diagnoses sleep apnea. I'm Charles Atwood. I'm a pulmonary and sleep medicine physician at the VA Pittsburgh Healthcare System and the University of Pittsburgh Medical Center. I am a active practitioner as well as an educator and researcher in sleep medicine, and I've been using the WatchPAT technology in my own practice for quite a number of years now. So we're going to go through this webinar, a fair number of slides to get through, but we've done this before, and we can almost always have time for some questions at the end, and I'll be happy to answer any questions. Also, just a reminder that if there's something I say that is confusing and you can't get it clarified in the Q&A afterwards, please contact your local NMR representative for either clarification or amplification of things that I talk about today. And we'll go ahead and get started. This is my introductory slide. The goals and objectives of today's meeting are as follows. We're going to talk about trends in home sleep apnea testing and some of the issues around that. We'll give an overview of the WatchPAT technology and the PAT signal itself and how it's unique and how it's a valid way of diagnosing sleep apnea. We'll talk about the detection of REM sleep and non-REM sleep via the PAT signal, and then kind of put it all together with what the PAT signal looks like in actual use, what the reports look like, get you oriented to those, and then talk a little bit about how well the PAT signal correlates with other types of diagnostic systems in obstructive sleep apnea detection, like primarily polysomnogram. We'll talk about the good, strong correlation between these two signals. Well, everybody knows that sleep apnea is a very common and costly disorder. It's under-recognized. It's both very common, but it's also under-recognized. And what this slide shows is two sets of data. These are disease-specific on my left, disease-specific prevalence of moderate to severe sleep apnea, the kind of sleep apnea that we're most concerned about treating, and these are different other disease states, and this looks at the prevalence of sleep apnea in conditions such as diabetes, polycystic ovary syndrome, coronary artery disease, CHF, AFib, and just the general population. So if you take the general population as the reference value, you can see that sleep apnea is overrepresented in most of these other clinical conditions relative to the general population. The general population itself, if you look at U.S. middle-aged adults, is over 20%. But if you look at something like type 2 diabetes or stroke, it's over 60 and approaching 70%. So very, very common condition associated with a lot of the key sources of morbidity and mortality that Americans and people in Western society in general deal with. And then on the other side of this slide, we have this pie chart showing how sleep apnea remains underdiagnosed and undertreated. If you look at the red part of the pie, this is at risk, but no diagnosis has been made and no treatment has been provided. And you can see that if you look at the population, the total population of sleep apnea potential sufferers, and you look at the blue piece that is separate, you can see that maybe only 15% of the people who are likely to have sleep apnea have already been diagnosed and treated. So there's a huge population of people that are below the radar screen who have not come to clinical attention yet, and these are our patients of the future, and these are people who are potentially suffering from the problems associated with sleep apnea but have not yet been helped to treat it. We know that sleep apnea has serious health consequences. These are data from Terry Young and the Wisconsin sleep cohort looking at mortality in two different ways, an overall total sample from the Wisconsin sleep cohort, and then a sample that excluded people in that study who are treated with CPAP. And you can see that if you look at the total sample, you have mild, moderate, you have sort of normal, mild, and moderate patients clustered up here at the top, and there's not a whole lot of difference between them. But then when you get to the severe group, AHI is greater than 30, you see that the survival rates over 20 years of or actually this is 18 years of follow-up, has a very, very different experience. And this is true certainly if you exclude the people who've been treated with CPAP, it's even worse. So sleep apnea has serious consequences. These data have been replicated in other settings, most notably the Marin study from 2005 in Spain, which kind of showed pretty much the same sort of thing. There's an economic cost associated with undiagnosed and unmanaged moderate to severe sleep apnea, with the estimates being between $65 and $165 billion. And this circle graph breaks down how these costs are attributed. You have public health costs, you have expenses associated with diagnosis and treatment. You have and these public health costs are sort of general health risks to the overall population. You have public safety costs associated with traffic accidents, which occur at an increased rate, damages to property, lost wages and productivity. And if you add all this up, it's between $65 and $165 billion. So a really significant amount of money is lost in a variety of different ways through untreated sleep apnea. And I think, as most of you know, the growth in the field of sleep medicine has been astounding. And this slide goes from the late 1970s to the present time. And you can see there has literally been, if you follow the red dot cursor, there's really been an exponential growth of sleep labs in the United States over this 35-year time frame. And the growth is starting to level off, but there is still there's still a lot of activity going on in the field. And we'll talk in a second about how some of this activity is shifting from traditional sleep labs to other forms of diagnostic and treatment activities. So polysomnography, since the early to mid-1970s, when it became clinically sort of viable, has been the mainstay of the diagnosis of obstructive sleep apnea. And it's a great test. Many of us on this call have spent many an evening or a day looking at full polysomnograms, an incredibly rich source of information about our patients. But they also come with some problems. Polysomnography is a relatively expensive test. It's a relatively burdensome test for patients. It's a burdensome test in a sense, for the healthcare system. There are inequalities in distribution of polysomnography around the country, and it's just a more expensive test, as I said. This shows the comparative cost or relative cost between polysomnography in the green bars and a portable study, a generic portable study, not any one particular one, in the blue bar. And you can see that if you just look at the relative costs, the home tests are capable of providing a considerable amount of savings over the cost of polysomnography. And this is not something that's been lost on the general public. It's not been lost on people in the sleep medicine field. In fact, beginning in the early 2000s, there was a concerted effort by some groups in the sleep medicine community to really push the agenda of home sleep testing much more aggressively and try to get it to the point where home testing could be considered an appropriate and reimbursable way of diagnosing sleep apnea. And there were some early attempts around 2003, 2004 that were unsuccessful, where people in the sleep medicine field petitioned CMS, Centers for Medicare and Medicaid Services, the people that run Medicare, petitioned them to allow home testing to be used to diagnose sleep apnea for the purpose of providing CPAP therapy. They were unsuccessful in that application. However, only 2.5 years later, they reapplied, and by 2007, when the hearings for Medicare were held, the evidence base for home sleep apnea testing was more robust and more consistent, and the proponents of home testing were able to successfully convince Medicare that it was time for home testing to be allowed to be used for the diagnosis of sleep apnea. So the tipping point in this slide is around 2008 when CMS had agreed to allow this to happen, and they put out what's called a National Coverage Determination, or NCD. That stood a little bit in contrast to what the American Academy of Sleep Medicine was putting out only a year earlier in their guidelines, consensus statements and guidelines about diagnosis of obstructive sleep apnea. They were still saying that polysomnography was favored and that home testing should only be used in certain carefully described circumstances. But by 2008, Medicare had sort of passed that over and had was allowing for coverage of home testing with a couple of provisos that we can go over in the Q&A time. But they allowed for it to take place, and that's really where the whole flavor of sleep apnea diagnosis and treatment began to change. So, and as you'll see on the next slide, there's been a concerted effort toward a move away from laboratory-based polysomnography to home-based sleep apnea testing. And you see on the left-hand side, in 2010, out of the millions of tests performed, about 90% was laboratory tests, 10% was home tests. 2016, it's about 75% home tests and about 20 to 25% laboratory tests. So there has been continued growth in the number of tests provided, but the type of test being used has changed quite a bit. And this simply shows a kind of a quintessential type 3 home sleep apnea test where you have a nasal cannula to measure airflow, you have a belt that goes around the chest to measure respiratory effort, you have a pulse oximeter on the patient's finger, and the pulse oximeter also measures heart rate. So you have 4 channels, you have 3 devices, the pulse oximeter has two signals, so you have a total of 4 signals. And this is what we would call a level 3 device, and this is the quintessential home sleep apnea test that when CMS was thinking about approving this, this is what they had in mind. With home testing, there is a number of important differences between laboratory testing, and one of the important differences is what is the denominator in the calculation of the either apnea-hypopnea index or the respiratory disturbance index. And home tests typically use recording time as the denominator, and of course laboratory tests use total sleep time. Well, total sleep time is always less than total recording time because very few, if any, patients, virtually no patients, sleep 100% of the recording time. So that number is always, the total sleep time is different from the recording time. And this little thought experiment kind of shows the implications of this. You have a typical home test where the apnea-hypopnea index is 5 events per hour based on a study of 9 hours. Where there are 40 events divided by 9 hours, that results in an apnea-hypopnea index of 4.4. So at 4.4, CPAP therapy would not be approved for this patient. However, if you take the same patient at the same time and did a laboratory test where you have a sleep time of only 3 hours instead of the recording time of 9 hours, then you have 40 events divided by 3. you get an apnea-hypopnea index of 13.3 events per hour, and CPAP is easily approved. So this just gives you an example of the differences between using sleep time versus study time. And if you can, you'd prefer to use sleep time. It's going to be a more accurate reflection of the apnea-hypopnea index. So now let's transition to talking about the WatchPAT as a technological innovation and how it's used to diagnose obstructive sleep apnea. The WatchPAT has a number of things in its favor. It's pretty simple to use. It's shown here in the picture. It wraps around the wrist. It has a single probe that combines the measurement of the peripheral arterial tonometry signal and pulse oximetry. It's easy to set up. It's simple. It's fast in terms of the time it takes to process it. Plus also there's really not much waiting time. It's something you can give to the patient. They can take it home. They can put it on themselves, hit the start button, bring it back to you the next day, and within a day you can have the results, as opposed to having to wait 2 or 3 weeks to get into the sleep lab, do the study, have the sleep lab piece have to be done and the study scored and interpreted and the report generated over the next day or two. So it's fast and it's predictable and it's highly reliable. All of the points which we'll show you as we go along. Another picture of the latest version of the WatchPAT Unified, where the finger probe has the PAT signal and oximetry and heart rate combined. There is the actigraph, which is built into the wristwatch part of this. This is in a sense, the CPU of the device. And then you have a body sensor that goes on the chest that helps determine body position, snoring, all in one device that sits on the chest. And in action, it kind of looks like this. You have it on the patient's wrist. The probe is here. The snoring and body position sensor is here. The WatchPAT has the ability to record 6 channels. It records peripheral arterial tone, which we'll talk more about, oximetry, which is familiar to you, actigraphy, which is familiar to you. That is motion of the wrist or hand that the device is attached to as a measure of wakefulness versus sleep, heart rate, body position, and snoring. And it takes all of this information into its proprietary algorithm and comes up with a measurement of a variety of key signals that are a part of diagnosing sleep apnea. And so this chart shows WatchPAT in kind of relationship to other commonly used diagnostic systems. So you have, up at the top, you have the highest number of signals. You have 8+ parameters in lab polysomnography or home polysomnography. Some people do home polysomnography as a clinical concern. It's mostly used as a research tool, but sometimes as a diagnostic tool. You have the WatchPAT, which has 6 signals. Below that, you have a variety of cardiopulmonary systems, such as the Embleta, the Aries, Philips, Stardust, and ResMed, Apnea Link, which have 4 to 5 signals, depending on how you think about them, including body position. And then at the most basic, you have 1 to 2 channels, such as pulse oximetry, which give you 2 channels. You can even get 3 channels in some instances if you combine an airflow sensor. That's something that's not as commonly done in the U.S. for a variety of reasons, but in Europe it's sometimes done. So you see how the WatchPAT has a relatively greater number of signals than some of these other devices, and has the ability, as we'll talk about, to measure total sleep time. You get a true sleep time measurement, and you get an estimate that's been validated pretty extensively of sleep stage transitions with the WatchPAT. So let's talk about the key signal that the WatchPAT has, which is peripheral arterial tone, or PAT. Peripheral arterial tone is measured by the measurement of arterial volume changes in the fingertip, and it serves as a continuous monitor of the digital, meaning the fingertip, vascular tone. And it's a reflection, therefore, because it measures this vascular tone of the sympathetic nervous system activation. The fingertip has a set of unique physiologic components that make it ideal for measurement of sympathetic nervous system activity. First of all, it's incredibly highly vascular with a high density of arteriovenous anastomosis. So there's a rich web of arterioles and venules in the fingertip that are constantly, in a dynamic way, changing with each pulse of the cardiac cycle. It's convenient. It's an easy place to access. You can develop devices that fit over the fingertip and measure this. It has a tremendous amount of blood flow, so it's really, there's a lot going on in terms of the dynamism of what's happening in the peripheral fingertips. Because there's a lot of flow, you can detect really minor changes very sensitively. Has a high degree of nerve endings, which are exclusively under the alpha sympathetic control. That's the alpha adrenergic branch of the autonomic nervous system. And that's the part of the autonomic nervous system which is incredibly susceptible, uniquely susceptible to apneas, hypopneas, arousals, hypoxia, all of the things that go along with having obstructive sleep apnea. PAT amplitude is simply the difference between the activation during systole and diastole. With each cardiac cycle, there's a pulse volume change, and the fingertip dilates and contracts excuse me, with the cardiac cycle. And that very minor change in blood volume in the fingertip with each cardiac cycle can be detected by the Innomar WatchPAT probe, which at its most basic level is a finger plethysmograph. You'll remember from your pulmonary physiology days that plethysmographs are devices that measure the change in volume of something. A finger plethysmograph is going to measure the change in blood volume of the finger, and that's exactly what the WatchPAT does. And this is an attempt, the next series of slides is to show you how the WatchPAT algorithm takes all of this input and comes up with its output, which is a measurement of the variables that go along with sleep apnea. There are three different components that the WatchPAT algorithm addresses. So there's, first of all, a differentiation between wake and sleep via actigraphy, and that's in the wristband part of the device. Secondly, there's differentiation between REM sleep and non-REM sleep. And thirdly, there's a differentiation between deep sleep from light sleep. And in the development of the WatchPAT algorithm, each of these different points was independently validated so that when you put it all together, you're not relying on some components being assessed and others not. Each individual component of the signal has been looked at and shown to correlate with its sort of gold standard, whether it's sleep stage analysis, wake versus sleep, light sleep versus deep sleep. And then finally, the whole package together has been extensively validated. In fact, there's no device on the market today in the home sleep apnea testing world that has greater validation than the WatchPAT. There's more studies for the WatchPAT than there is for any other device. And in fact, basically, there are as many WatchPAT studies as there are the rest of the literature combined. Sleep is differentiated from wake by the amount of and the pattern of movements in the actigraphy signal. So that kind of makes sense. Actigraphy has been used for decades to distinguish wakefulness or wake activity from sleep activity. In terms of REM sleep, REM is associated with more sympathetic activation and pulse rate variability than non-REM sleep. So you can look at the changes in the PAT signal that go along with relatively more sympathetic stimulation or less, and that correlates quite well with the presence of REM sleep versus non-REM sleep. And then light sleep simply has more variations in the PAT amplitude and pulse rate than does deep sleep. Deep sleep is a time of tremendous homogeneity in the cardiovascular and respiratory signals. There's not a lot of variability in heart rate or blood pressure or respiratory rate during slow wave sleep. During lighter stages of sleep, such as stage 1 and stage N1 and N2, there is more variability. So you can begin to distinguish lighter sleep from deeper sleep based on that characteristic. So these sleep stages have different sympathetic signatures in the PAT signal, and over time, ITMR has become very good at identifying these different signatures and understanding how they differ from one another. This slide simply shows how the PAT signal looks in different types of sleep. So on the left you have light sleep, shown here, and you have a pretty large amount of PAT amplitude. There's not a lot of attenuation in this signal. On the very top, this is the raw signal. The PAT amplitude is the rectified signal, which basically summarizes the trends of the PAT signal. You have the pulse rate here, showing that during light sleep there's a certain amount of variability. During deep sleep there's a lot less variability in the heart rate, and the same as there's kind of less variability in the PAT signal as well. And then when you go into REM sleep, you get, once again, a lot more variability in the pulse rate, and you see the PAT signal, because of the sympathetic nervous system activation that's been described as a part of being in REM sleep, you get this attenuation of the PAT signal. You can think of this as peripheral arterial vasoconstriction associated with REM sleep. On this slide, just another way of kind of making the same point. You have a polysomnogram where at the bottom you have the PAT signal displayed. You have more traditional polysomnogram signals up above, and you have REM sleep, and you have stage N2 sleep. During REM sleep, you have this PAT signal attenuation and variability, snoring shown here, and then when they go into stage N2 sleep, you can see that the vasoconstriction that's a part of REM sleep is released, and you get this gradual vasodilatation that's much more a part of non-REM sleep. Well, why does this distinction between REM and non-REM sleep matter that much? Well, there's been a considerable amount of interest in this dichotomy between REM sleep physiology and non-REM sleep physiology for a long time, but only recently has there been much in the way of clinical emphasis put on these physiological findings. But there's now been a number of studies, 3 of which are shown here, which show that REM sleep, obstructive sleep apnea, is associated with reduced glycemic control and type 2 diabetes, as opposed to just non-REM sleep. There is another study, which has, in number 2, which has shown that obstructive sleep apnea during REM sleep is associated with hypertension compared to overall sleep apnea as the comparator. And then finally, obstructive sleep apnea during REM sleep and incident non-dipping of nocturnal blood pressure. Non-dipping of blood pressure is a abnormal signal that usually implies that there is some dysregulation in the cardiovascular system. And so the fact that that's associated with REM sleep, obstructive sleep apnea, is important. So let's talk a little bit about how you diagnose sleep apneas via the PAT signal. Just to remind you that the PAT signal works off the sympathetic nervous system, as we've discussed. There's another part of the overall autonomic nervous system called the parasympathetic nervous system, and it's sort of the opposite of the sympathetic. So you remember that the sympathetic nervous system is the one that's associated with stress. It prepares the body for attack, to fly, for fight or flight. So what goes along with that? Increased heart rate, increased respiratory rate, pupil dilatation, makes it easier to breathe, predominates during wakefulness, and it's also very much at work during phasic REM sleep. The phasic part being when the eyes are moving rapidly, that part of REM sleep. Now, by contrast, the parasympathetic nervous system is more restorative. It inhibits and restores organs. It inhibits the fight or flight part of the sympathetic nervous system, so it's in a sense restorative. It prepares the body for normal functions. It's, in a sense, it's the rest that you get during sleep is associated with increased parasympathetic tone. The heart rate slows down, blood pressure goes down, and it predominates during non-REM sleep and during tonic stage REM sleep. Tonic being the part when there's not rapid eye movements. And this simply shows a more complex way that the PAT signal detects sympathetic-mediated vasoconstriction due to obstruction and arousal. So just as we've seen before, we have mild obstruction, severe obstruction, and again, severe obstruction. So if you look in the mild obstruction, you have polysomnogram channels at the top, and then at the bottom you have a rectified measurement of the PAT signal. And you have esophageal pressure here and airflow here. So you see during the mild events, there's not really very much change or attenuation in the PAT signal. You go to a more severe obstruction, and you see you have apnea here. Here you have a little bit of decrease in airflow, but here you have a true apnea. And you'll see in this event here that subsequently you see a little bit of PAT signal attenuation. So here we're normal. Here you have the event, and here you see the effect of that event with this PAT signal decrease. Now, if you look at the case of severe obstruction where you have the severe event followed by an arousal, then you get the PAT signal attenuation from the event itself plus the effect of the arousal, and you can see that the PAT signal is markedly more attenuated with the apnea and the arousal present. Well, because we're talking about a device that uses the sympathetic nervous system as its prime sensing part of physiology, there are things that affect the sympathetic nervous system may affect how good the signal is that we get. So there are some medications that you need to be aware of that may attenuate the PAT signal. So anything that antagonizes the alpha adrenergic nervous system could potentially affect the integrity of this signal. So drugs like prazosin or terazosin are the most notorious offenders in this group. Beta blockers to a lesser extent, because beta blockers are working on the beta adrenergic nervous system, not the alpha adrenergic system in most cases. However, as you know, there are some beta blockers that also have some alpha effects as well. Agonists that affect the alpha adrenergic system include phenylephrine and clonidine. These may be usually are not a problem because they're not antagonists, but they may change the signal intensity to some extent. Also, short-acting nitrates, because they rapidly vasodilate, may have an effect as well. And this shows the PAT signal and how it relates to respiratory events. When you are having normal respiration, there is a kind of a waxing and waning of intrathoracic impedance as you breathe in and breathe out. The pressures in your chest change. That changes blood flow in your chest. That changes cardiac cycle. With each respiratory cycle, there's an effect on the cardiac cycle. When you stop breathing, there is a almost instantaneous sudden surge in sympathetic nervous system traffic, and that can be picked up by the WatchPAT detection device on the fingertip. So you have here, you have airflow shown in the signals here, then you have an apnea, airflow, apnea, airflow, apnea. Look at the PAT signal. You have airflow here, you have attenuated PAT signal, which is from the apnea that preceded this airflow. Then as the airflow is working, you see that there's a vasodilatation in the PAT signal. Now there's an apnea, and again you get attenuation. Then you have the increased respiratory cycle, you get vasodilatation. You have an apnea again, you have attenuation. So you can see that there is about a 90-degree, about a 180-degree phase lag between the airflow signal and the PAT signal. But it's pretty predictable, and you can use that to understand how the PAT signal works in the setting of respiratory activity. And this is a little bit of a deeper dive looking at the association between the PAT signal and the sympathetic marker at the end of each apnea episode. So here you have an apnea, hyperpneic breaths, apnea, hyperpneic breaths. You can see the PAT signal here, how at the end of the apnea preceding the hyperpnea here, you get this attenuation, but then you get vasodilatation, vasoconstriction, vasodilatation, vasoconstriction. These are pretty clear-cut signals, and this is kind of how the PAT signal actually looks like, what it actually looks like when you see it on such a patient. It's pretty dramatic. And here's a good example of a real live PAT signal where you have respiratory event arousals, you have vasodilatation, you have vasoconstriction, vasodilatation, vasoconstriction, and association with changes in the PAT amplitude, pulse rate, and SaO2. Again, if you take the PAT signal and look at the PAT amplitude and the pulse rate, you'll see that they often look like they're in paradoxical relationship to one another. It's because they are. When the heart rate goes up, that tends to cause vasoconstriction, and you see the PAT amplitude decrease, and you have a PAT event. Hypopneas and upper airway resistance syndrome also have an effect on the PAT signal, as shown here. You have some hypopneas, nasal airflow, and abdominal belts. You can see that there is PAT signal attenuation as a result of this, shown here, and further along in different places you can see the effects of decreased airflow, like a hypopnea or URs, and how that affects the PAT signal. Central apneas are also shown here. They can have an effect on the PAT signal. The device is not yet approved fully for central apneas. It's under review by the FDA at this point. But if everything goes well, then at some point this will be approved for central apnea detection as well as obstructive apnea detection. This is what central apnea Cheyne-Stokes respiration looks like in terms of the PAT signal attenuation, shown here. Again, you have an apnea followed by the PAT signal attenuation. You have the hyperpneic breaths showed by vasodilatation. And then other things that can cause arousals, especially autonomic-based arousals, can have an attenuation effect on the PAT signal. So if you have periodic leg movements with autonomic arousals, you can have this waxing and waning of the PAT signal in response to the leg jerks, which are causing PAT signal attenuation as a result, from this one to here, this one to here, this one to here. And you can see that the PAT signal waxes and wanes with these PLMs. Now, this results in the opportunity to do a little bit of interpretation, or the need to do some interpretation when you have a comparison or a significant difference between the respiratory disturbance index on one hand and the apnea-hypopnea index on the other. So when you see the RDI exceeding the AHI, think about whether there's upper airway resistance syndrome present, whether there are periodic limb movements present, or whether there could be insomnia present, where there are other things that are attenuating the PAT signal in insomniacs. Here's a typical report of what the WatchPAT looks like. You have, and we'll take each of these components separately, but you have the study characteristics here. You have an overall summary of the respiratory indices. You have a breakdown of some of the oxygen saturation statistics. And then you have some representative examples of what the signals look like over the course of the night. These are highly summarized signals, but they're valuable. You can look, for instance, at the oxygen saturation values here and say there's probably 1, 2, 3, 4 REM periods during this study, because these desaturation periods probably line up pretty well. And you can see here that the patient has both a very elevated RDI and an elevated AHI, pretty close to the same. And the oxygen desaturation index, or ODI, is also shown. These are the study characteristics showing the study start time, the finish time, and the total duration of the study. These are the PAT RDI, PAT AHI, and ODI signals broken down by REM stage, non-REM stage, and overall. And this panel looks at the oxygen saturation statistics. You can see that this patient has 5% of saturation less than 90%. This one has 2.6% of the study time with an oxygen saturation less than 85%, and so forth. So you get a pretty good measurement of oxygenation in ways that make sense to clinicians. And then the WatchPAT report shows the various indices that are being measured, so you can get a sense over the entire night what trends in this kind of analysis look like. And then the second page of the report has further sleep body position statistics, snoring statistics, sleep stage, sleep weight statistics, and then a breakdown of the PAT RDI, the PAT AHI, and the ODI signal. And this is just more detail about this. And then the final page shows the sleep, or the bottom of this page shows the sleep study statistics for this particular recording, including the respiratory indices chart. So we've talked about WatchPAT and how the signal is made, what it means, and how you can begin to think about it in diagnosing obstructive sleep apnea. How good is the signal in relation to polysomnography, which is probably its largest competitor in the sense that if you're comparing something to the reference standard, polysomnography would be that reference standard. And fortunately, it turns out that the PAT signal and the polysomnogram signals correlate pretty well. This is a line of identity drawn through plotting RDI from a WatchPAT versus RDI from a polysomnogram. You can see that the line going through these plots is pretty much the line of identity. It's pretty relatively little scatter. And this gives an example of WatchPAT ODI and RDI estimates. This is a forest plot taking into account several different studies that have looked at this question. And this simply looks at the ODI correlation between the PAT signal and PSG. It's highly, highly, highly significant with a R value of 0.94, which is astoundingly high in clinical medicine. And then a PAT signal correlation with polysomnographic AHI alone, an R value of 0.89, again, extremely, extremely high. Well, how do you incorporate the WatchPAT technology into a cohesive portable monitoring program? Well, you have a traditional model which says you see a sleep clinician for a clinical evaluation in the office. You then would have an in-lab polysomnogram followed by an in-lab CPAP titration, assuming the study is positive. And then you would obtain the CPAP prescription, get the machine, take the machine or the prescription to a home care company who would provide you with that equipment. Now compare that with the home testing model, where you still have a sleep clinical evaluation. You do a home portable monitor. That's positive for sleep apnea. Do a home APAP titration. And then you get a CPAP prescription where the CPAP is set either in a fixed mode, such as at the 90th percentile pressure or 95th percentile pressure, or you get a auto CPAP machine, which stays in the auto mode, and you simply adjust this. The machine self-adjusts against the sleep apnea every night. There have been a number of clinical trials using the WatchPAT specifically as a way of diagnosing sleep apnea. And perhaps the best well-known study is one by Rich Berry at the University of Florida and the Gainesville VA Hospital. This was a study done largely in veterans. 106 patients were randomized to a home WatchPAT followed by an auto-titrating CPAP machine versus a sleep lab, polysomnogram, and CPAP titration. They looked at patients at 6 weeks later. And what they found was that CPAP acceptance, compliance, Epworth score, functional outcomes, CPAP satisfactions all compared. They were all basically the same. And when they looked at adherence, they found that acceptance and adherence were markedly better. CPAP adherence and clinical outcomes were the same between the home arm with WatchPAT and the sleep lab approach. So this was one study using a new approach where you do the home test followed by auto CPAP, all in the home versus laboratory. The American Academy of Sleep Medicine Foundation has done another study, a somewhat larger one with about 373 participants, looking at the same question about home diagnosis, although they did not use WatchPAT, followed by home auto CPAP versus everything done in the laboratory, and they found that the results were the same, that basically adherence was no different between home evaluation versus lab evaluation. And as in the Berry study and as in other studies, there was a trend, albeit non-statistically significant, the home approach yielding a somewhat better adherence, although not statistically significantly better. So how do you actually use the WatchPAT? Well, there's a number of different ways, and I would say actually this is a work in progress. The way that we use the WatchPAT is evolving. You can use it where there's a very high index of suspicion and you basically just want to nail down the diagnosis so that you can get the CPAP started. You can use it in situations where you want to judge the effectiveness of sleep apnea therapy. So perhaps you have somebody on CPAP and they're not doing so well, or they're doing positional therapy or an oral appliance, and you want to find out how successful is this particular therapy. You can simply put the WatchPAT on them. Doesn't really interfere with them being on CPAP or using an oral appliance. Do a recording and see how successful they are. If you have patients that are really anxious about coming into a sleep laboratory or anxious about wires on their head or belts around their chest, you might be able to assuage their concerns by using a WatchPAT, because you're going to have far less on their body. You're going to have a wristwatch-like device and then something that is attached to their fingertip and to their chest, and that's it. You can use it for inpatients. You can, for people who have who are in the hospital and for whatever reason they need a sleep apnea evaluation. In my own practice, we did one last night on an inpatient who was admitted with a congestive heart failure evaluation or exacerbation. We were asked to see him about PAP therapy for his what was presumed to be sleep apnea. So we did a WatchPAT study on him last night. It worked out well. He has moderate sleep apnea, and we will take it from there in terms of treatment. But the WatchPAT worked great. It was done in his bedroom. We got good data, good recording, and we were able to make a diagnosis of his breathing problem in a way that doesn't involve him coming to the sleep laboratory or doing extra special tests. And then finally, if you have patients for whom manual dexterity is a problem or cognitive problems, this is a simple test to do, simpler than doing some of the other setups for home equipment. As I said earlier, the WatchPAT is the most studied home test available, has over 180 studies to date. It is highly correlated to polysomnography as verified in 2 meta-analyses. Using the WatchPAT over or instead of polysomnography oftentimes can speed up the evaluation and reduce healthcare costs, because polysomnography is easily 3 times as the cost of doing the WatchPAT. And then the home-based strategy for diagnosis and therapy is not inferior to the traditional PSG approach. That's been shown now in 5, actually more than 5, more like 7 randomized controlled trials from the late 2000s to the present time. So there's at least 7 studies which have shown this now. So let's do a case report and show you how the WatchPAT kind of helped out with a challenging patient who might have otherwise gone undetected for sleep apnea. So we had a 59-year-old female with a long-standing history of insomnia. She has frequent awakenings with difficulty getting back to sleep. She has a history of snoring and some snore-related awakenings. She had an overnight oximetry, should be not 2001, should be 2010, which was read as normal. She has a history of mild RLS, which is managed with pramipexole. Her husband says that her snoring is getting worse. She's sleepier. Her Epworth scale is 13. She has a dry mouth in the morning. And she, like many people now, wears a Fitbit 24/7. And so she downloaded her Fitbit report and brought it in and looked at it. And it looks like it was slow sleep efficiency with lots of awakenings. So you do an overnight oximetry on room air, and you see that the oxygen saturation up here is above 90% almost all of the night. Here it dips below 90% only very briefly. So you're not going to make too much out of this. But nonetheless, the patient's symptoms are still concerning for sleep apnea. So you do this oximetry. Here's the oximetry results. You do a WatchPAT, and you get a different answer. Here the sleep time is 4 hours and 44 minutes. Not the longest sleep time in the world, but one that's probably adequate. If you look at the RDI, you get 13.5. You look at AHI, you get basically 13. And the ODI is about 5. There's a little bit of oxygen desaturation here. This is what the events look like. And this is what the rest of the report looks like. So this patient's report was an apnea-hypopnea index of 13, an RDI of 13.5. Definitely enough to justify prescribing a CPAP machine, and that's what in fact happened with this patient. So you can see how the WatchPAT technology helps sort out patients who have confusing presentations without resorting to bringing them into a much more expensive sleep laboratory setting. So in conclusion, the WatchPAT home sleep test system is the easiest home test on the market. It really requires minimal time to train the patients or your sleep laboratory technologists. It's fast. It has a comprehensive report that's generated from the data within a few minutes. It is clinically validated against polysomnography, and it's reliable. It's been used by over 1 million patients, has a low failure rate in home sleep apnea testing administration or hospital sleep apnea patient administration. It's easy to use and robust and accurate. And so these are all the things, these are all the characteristics that you really want in a home sleep apnea testing device. All right, so that concludes the slide portion of the presentation. We have about 5 minutes left for questions. If there are any questions, I'll have the operator read them out, and I'll try my best to answer them.
And we do have some questions submitted. First question asked from Jim, Dr. Atwood, could you explain the difference between the PAT and relying on arterial tone?
The difference between the PAT signal and arterial tone, well, the PAT signal measures arterial tone in a specific setting in the fingertip in these particular vessels that are characteristics of the fingertip. Arterial tone can be measured in other ways. You can do you can measure brachial artery size. You can do pulse wave technology, which is a slightly different technology. So there are different ways to measure arterial tone. The PAT signal, I sort of view it as the one that's the most has the best validation studies associated with it, and the one that's been put into a device that is routinely commercially available.
Our next question comes from Ledhaven. Can you clarify if medications like prazosin interferes with the result?
Yeah, so as I mentioned, prazosin, terazosin could affect the results. It's not 100% always, it's not a 100% foregone conclusion that it will invalidate the results. But if you have somebody on prazosin and you get results that don't look correct or are at odds with what you suspect clinically, consider taking the patient off prazosin for a few days if that's clinically justifiable, and repeating the study and see if you get a better result. It used to be thought, because this may be a question, it used to be thought that atrial fibrillation was a contraindication. That's really no longer considered a contraindication to using WatchPAT. The technology is robust enough now so that atrial fibrillation doesn't invalidate the study. But if you have problems with the results and the person is on prazosin or such an alpha antagonistic drug, consider taking them off and repeating it.
Next question. Why are we reluctant to call OSA and still use the terms URs or UARS with a high RDI?
Why are we reluctant to use the term UARS? Is that the question in the setting of this in the setting of some types of sleep disorder breathing? Not entirely sure why we are. I think a lot of people still use the term UARS. One reason may be that if you are dealing in the insurance reimbursement world, you would rather have a clear-cut case of OSA than UARS. The insurance company may use a UARS, or upper airway resistance syndrome diagnosis, to exclude somebody from getting CPAP therapy because they say, well, this is not sleep apnea, this is something else. That may be one reason, but there are probably many answers to that question.
And we have two more questions. Next one, how do we use the ODI?
That's a good question. So the ODI, oxygen desaturation index, is really, it's all wrapped in physiologically with the AHI and RDI. The ODI is a standalone measurement, might be used in a situation where you have somebody with mild sleep apnea, or maybe they don't have sleep apnea, but they have a lot of desaturations because they have underlying lung disease or maybe heart disease. So you get an ODI that is elevated because you're having more than 3% dips in the oxygen saturation, but instead of being due to sleep apnea, it's due to something else. That may be a tip-off there.
And our last question from Jim. If the person drinks alcohol, do you ask them to drink during the WatchPAT test?
That's a clinical question where you kind of have to use your own clinical judgment. If somebody has a single drink and that's just part of their normal bedtime routine, my approach is to say just keep to what you normally do. Now, if somebody is having 4 or 5 drinks at bed, close to bedtime, that's a whole different story, and you might have to think about how the study results are going to be used or whether they would be valid in the setting of such heavy alcohol use. But again, that's more of a clinical judgment question that gets into how you like to practice and what your beliefs are about how the studies ought to be conducted.
And Dr. Atwood, if you don't mind, we do have just one more question with regards to the UARS. But I haven't asked, since the pathology is the same and RDI points to pathology, why can't we omit the term UARS and start using the term OSA or OSA?
Say that again?
Sure. Since the pathology is the same and the RDI points to pathology, why can't we omit the term UARS and start using the term OSA?
I think that gets at the issue of definitions. The RDI and the AHI have slightly different technical definitions. If you take Medicare as an example of somebody who pays for health care costs or as an insurer, Medicare has specific definitions that they like to see for AHI in order to be indicative of having sleep apnea. Now, I do sense that there is some sort of softening of the rigidity of insurers between the AHI and RDI. So your point is a valid one. Because you're right that the pathology or pathophysiology of these events is the same, why not just call everything OSA? Why not just make the RDI and AHI kind of interchangeable? I think that's a fair question. It comes down to how insurance companies view definitions and how rigid they are about keeping to these definitions. I'm fine with fuzziness, but not everybody else is.
Thank you, Dr. Atwood, and that's the last of our chat questions. Any final closing remarks?
Thanks, everybody, for your attention. I apologize for my coughing, but that's the way sometimes your voice gives out when you're talking. Follow up with your Itamar representative for further details about the equipment and other questions about the interface between the equipment and clinical decision making. They're excellent people who can help answer some of those questions.
Thank you, Dr. Atwood. And ladies and gentlemen, this concludes today's Itamar Medical webinar. Thank you all for attending.
The moderator has ended the conference.